itu sudah Pak. Mm, 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 mm.
കേൾക്കണല്ലോ. സ്പീക്കറിന്റെ ഉള്ളിൽ
Good evening, sir and team. Good evening, sir and team.
സ്ക്രീൻ ഷെയറിങ് ഇവരല്ലേ പറയുന്നത്?
അല്ല, സ്ക്രീൻ ഷെയറിങ് ഇവിടെ ഇതാണോ സ്ക്രീൻ ഷെയറിങ്?
അതെന്തിനാ?
അല്ല, അത് നമ്മളൊക്കെ കാണണമെങ്കിൽ അതല്ലേ, എല്ലാരെയും കാണണമെങ്കിൽ എങ്ങനെയാ അത്?
You cannot start screen share while the other participant is sharing. നമുക്ക് പറ്റില്ല, മറ്റാളെ ഷെയർ ചെയ്തോണ്ടിരിക്കല്ലേ.
തുടങ്ങുമ്പോ മാത്രം അങ്ങനെ കാണാൻ പറ്റും.
ഇപ്പൊ അവരുടെ വീഡിയോ വേണമെങ്കിൽ ഇവിടെ ഓഫ് ചെയ്യാം.
Good evening, Paili sir and team Rajagiri.
Good evening, madam.
Good evening, madam. Good evening, Venu.
Good evening, Ajit, Venu.
Good evening, madam.
Good evening, Dr. Paili.
Good evening, Paili sir and team.
It's live on YouTube, so everybody is requested to please mute unless asked otherwise. Stop. Ajit sir, good evening.
Good evening, madam.
Kaushik sir, are you around? Sir, start here, sir. Ajit sir, one no?
Yes, Venu, I am there.
Okay. Yes.
Kaushik is there.
Yes.
Good evening, Dr. Ajit. Good evening, Ambuja madam.
Good evening,
Kaushik, can we mute everyone?
Venu, the mute function is enabled. So whenever, anytime anybody joins in, you'd be muted only. But it's if people still able to unmute themselves, so that is the problem. You cannot disable that function.
Hello, Venu.
Paili sir.
We are audible?
Yes, very much, sir.
Okay, then we are ready whenever you feel like.
Yeah, just a couple of minutes, sir.
Okay, that's fine.
Yeah, we'll be on time, as you say.
Okay. We are ready. Anytime we can start.
Right, sir, we can see you.
Venu, can we start?
Yes, sir.
Yeah, please go ahead.
Yeah, just a minute, sir. Just a minute. Yeah. Very good evening to all of you. Now today, without any delay, we will start our second meeting in the series of meetings on COVID, the COVID respiratory support for COVID pneumonia. This meeting, we have respiratory supports basic to advanced, which is coordinated by a team from Rajagiri Hospital. I welcome our president, Ajit sir, to begin the meeting by giving his lines of introduction. Ajit sir, over to you.
Good evening. Thank you, Venu. Good evening, dear seniors and friends. There is no doubt now that we are seeing more symptomatic women in this second wave of COVID. Even though they are asymptomatic, decompensated at any time. So that is why we always recommend the SpO2 monitoring at home, as well as a 6-minute walk test. They may need respiratory support anytime. In the last week, we discussed the role of steroid, timing, dose, selection of steroids, all these things. The role of heparin. Actually, these are the two medications that make mortality benefit. And we also discussed about the timing of delivery. And the summary of the same is nicely put by Dr. Sangeeta Menon. And I thank Dr. Sangeeta for the same. Today, we are going to discuss another very important area, the respiratory support in COVID pneumonia, by the experts from the Rajagiri Hospital. I take this opportunity to thank Paili sir for arranging it. I also thank Dr. Kausiv and Dr. Iyer of UNICEF for providing this platform and supporting the Kfog in all these things. Over to Venu. Thank you.
Thank you very much, Ajit sir. Before we proceed to the meeting and hand over to Paili sir, just a few one or two observations to make. First is, like Ajit sir said, our sincere thanks to the UNICEF South, Kaushik Ganguly sir, for having provided the platform. I wish to remind all in the audience that today is a demonstration session. So all the doubts you have, you may put it in the chat box, and Paili sir and his team and rapporteurs will attempt to answer it in the course of the demonstration. Please do not speak out of turn and attempt to make one-to-one conversations here. Another thing is that there is a doodling or annotation that can be done on the screens. I request all participants to keep courtesy and prevent annotations being made and doodling on screens. This is just because we have made some observations. Over to you, Paili sir. Best wishes and happy learning to all those who have logged in. I also wish to remind everyone that if people are, if your friends are having some difficulty logging in, this meeting is being live streamed on our YouTube channel also. Thank you very much. Paili sir, over to you.
Thank you, Venu. Thank you for your support.
The
introduction has already been made. Why we thought of having this session is, the impression I get from across the state is, it is no more the critical care or intensive care specialist or anybody who is going to look after these COVID patients. It has been now passed on to the obstetricians. In the major centers in our state, the obstetricians have to do more than just obstetric management at the moment. And this certainly applies to the periphery. That is why I thought some of the basics about giving oxygen support, which is the need for a COVID pneumonia or a COVID affected patient, we will discuss. And I am so grateful to the team which has joined me to deliberate on this. Let me introduce my friends here who have agreed. Dr. Jacob, can you just raise your hand, Jacob? Jacob, can you zoom in? Zoom in. Jacob is the head of the critical care department in our hospital. And Sachin George, Sachin, just raise your hand, please. Sachin is the anesthesia head of the department. And we have Julius, accident and emergency chief over here. Vivek, and then Nitish, who is in charge of the critical care ICU, and Della and Alan, please come onto the screen. They are respiratory therapists who look after our patients over here, and my own colleagues, Raji and Saumya, they are there to act as rapporteurs, and of course Ajit is here to help us with the IT. So this is the team. What we thought was, we will go straight away, depending, zoom out. Yeah, we will go straight away to discuss some of the practical issues that are likely to come up. Let me first of all bring out the point. COVID affects primarily the lungs. And when the lungs are affected, as we already know, it affects the oxygen saturation, oxygen uptake, and oxygen delivery. So our aim in managing a COVID patient, other than the obstetric management, is to know about these things, the physiological changes, as well as what to do at that time. Friend here, Jacob, to show us some of the pictures of the lungs which he has come across. We have the PowerPoint slides, please.
Good evening, all respected doctors, and salute from the team here, because we have been reeling under the pandemic for almost more than a year right now. I think the perseverance and the teamwork and the togetherness will make it, we will be able to overcome. These are all academic things which we will like to share and share our thoughts, and we will also be happy to take from you also, because sharing of knowledge is important. Thank you, Paili sir. Thank you, Kfog, for giving us that opportunity. So let me start my talk with the first topic we thought may be relevant is to show you how badly this virus can affect the lungs. I'm not going to talk anything on this. This is purely to make you just re-emphasize the fact that the COVID pneumonia is something which may not happen all of a sudden in a COVID. Most of the patients, you know that we have a term called as post-COVID. COVID may become negative after 10 days and then the problem starts. However, what is important is that onset of symptoms, onset of lung involvement, we all know the viral phase, we all know the immune phase, and the lung is affected mainly because of the inflammation or the immune phase of the COVID disease, not mainly by the virus directly infesting the immune reaction which the body happens. That is why the lung is getting affected. The median days is 6.5 days. So it may not happen immediately. That is why we need to monitor any patients, especially a pregnant patient, because the median days is 6.5 days. Once the symptom starts, the ARDS can progress within 2.5 days. That is what is the key. And another important thing which makes this COVID pneumonia notorious is that the hypoxemia what we normally have will be asymptomatic. Patients may not feel it. That's what we have the term called as asymptomatic hypoxemia. Now this is a example. This is not a real patient what we had. This is from the first case series published in NEGM in January 2020, the start of the pandemic. How the X-ray worsened on admission and after 24 hours in a COVID patient who came symptomatic. This is how we can clearly make out. Somebody, there's a lot of opacities in the both the X-rays. Now, I just want to put some picture to real patients we have. This is a 29 weeks primary, 24 COVID positive, admitted on 24/4 in our hospital, and this is an X-ray. X-rays infiltrate, which is more or less located in the peripheries, which is a classical of the COVID. However, CT scan will be of help in settling a lot of things. This particular patient, after discussing with the gynec team and the family, we got a CT done, which helped us in management. And this classical picture of a COVID pneumonia. What you can see here is that, look at the peripheries, there's a lot of peripheral opacities, which is asymmetric in both the lung field. This is both cuts are there here. So this peripheral ground glass opacities, which is asymmetrically found in both the lung field, is the classical picture of a CT image in a COVID pneumonia. I'm not a radiologist to comment more about it, but for a basic knowledge of our understanding, this is a classical picture. And based on the lung scoring, radiologists will score, and they score from 25. Less than 8 is mild, 8 to 15 is moderate, more than 15 is considered as a severe COVID pneumonia. That is what we classify. This is the classical peripheral opacities. Second patient who was brought to us 34 weeks LSA was done outside. Then she was brought to our hospital, and this is the X-ray. She was intubated in the ER. This is the X-ray on admission when she came to our emergency room. And we also, after intubation, since it's a post-cesarean from outside, we got a CT done. And you can see some difference between the first CT and second CT. Yes, there is opacities in the both lung field, which is more severe than the previous one. However, what difference I can tell is that there are ground glass opacities, but on top of that, there is some sort of a dense area in the both posterior, which could be a consolidation. And you can also see a lot of gradient difference between coming from anterior to posterior. So this can be COVID pneumonia plus possibly a consolidation secondary infection, And third possibility could be there may be a fluid, a pulmonary edema component also because of the gradient difference coming from anterior to posterior. This is another classic CT film of another patient. This is another patient, 36 weeks gestation. She was LSES done again outside, and she was again transferred to us because of the worsening dyspnea post day 1. First X-ray, you can see that most of the lung shadows are white out. Now this is a CT of this particular lady. Again, the opacity is what we see. It may not be classically peripheral, however, this may be a bit more severe form, and the diffuse ground glassing is there. This is more diffuse than the previous one. The previous one were patchy ground glassing. This is a diffuse ground glassing. However, if you look at the posterior lobe, you can see it is more dense. This is more of a consolidation. So definitely there can be a secondary infection with a ground glassing. So CT can help us in diagnosing a COVID pneumonia. You don't need that, but you need to have the prognostication. Number 2, additional complication of a COVID pneumonia like a consolidation, secondary infection, and fluid component can be reasonably made out in the CT. However, let me put across, we won't be able to do CTs for all pregnant patients. X-rays also are relevant. X-ray also can tell us the grade. This is an example of a 28-week gestation primary, which we didn't do a CT for this patient. You can see ground glassing opacities here with peripheral plus central combination of things, and both lung fields are involved. Now, I would like to emphasize on one important thing. One of the classical or one of the most problematic finding of COVID pneumonia is you develop what is called as a pneumomediastinum without a pneumothorax. And this is a guy, this is not a female patient, male patient who has come with the COVID pneumonia. And you can see over here, this is the air shadows where it's coming straight into the diaphragmatic area. And you can see this picture. Normally you see a gap over here, but you can see the lung is continuous over here with an air shadow. This is a classical finding, and the vessels over here also are covered with air. So when you see a continuous diaphragmatic sign or a mediastinum which is continuous with a black shadow, this is a classical of pneumomediastinum. This is the last picture. This is a COVID pneumonia which is progressing. This is basically a COVID pneumonia with a lot of reticular shadows, which is, and some fibrotic areas over here, which is a progression to a ARDS, which is persisting and progressing. This is what a classical picture of a COVID look like. Over to you, sir.
Thank you, Jacob. So it shows us how badly the lungs can get affected, from a simple form to how badly it can get affected. And in that case, would you like to share with us, Vivek,
Yes.
the changes in lungs that happen in pregnancy and why in COVID the lung involvement in pregnancy becomes so significant? Can you just...
Good evening, one and all. Thank you, Piley sir and team, for giving me this opportunity. Myself, Dr. Vivek T. Manachari, a consultant in anesthesia and charge of the surgical critical care. I have been interested in this topic, the basic respiratory physiological changes that happen, and I would be introducing you to a few terminologies. So without much delay, I'll go into my topic here. So in this picture, I think I have explained almost most of the things. So the most common organ that is affected is the respiratory system. So starting with the upper airways, I would say there are a lot, because of the hormonal changes, the mucosal edema and the hypervascularity occurs especially in the upper respiratory tract, in the nose, nasopharynx, larynx, and even in the trachea. So the clinical implication is that there would be definitely difficulty in the airway management, and hence we always try to use a smaller size endotracheal tube. Normally we use 7 or 7.5. You can use a smaller size, maybe a 6.5 or 7. And then comes about the diaphragm. There is actually a pushing up of the diaphragm because of the gravid uterus, about 4 centimeters, and this causes a decrease in the functional respiratory capacity. What I mean by this is the oxygen reserve in the lungs decreases, and hence there are high chances of hypoxemia, especially during apneic periods. And definitely even the stomach is having there is reduced gastric motility, and definitely there is an increased intragastric pressure. So there is high likelihood of aspiration in a pregnant patient. A few physiological respiratory changes would be, there is an increase in the minute ventilation. That is usually because of the increase in the tidal volume and also because the increase in the respiratory rate. And what happens rate is carbon dioxide gets washed out and there is a respiratory alkalosis that happens. And to compensate for this, there will be a metabolic acidosis as well. Next point I would like to emphasize is the increase in the oxygen consumption. The oxygen consumption is increased by approximately 20%. And the functional residual capacity, as I had already mentioned, it comes down by around 25%. And lastly, the chest wall compliance. Actually, the chest wall compliance is reduced, and the diaphragmatic movement is increased, and hence there is a decrease in the transalveolar pressures. I just summarized the whole thing in just this small slide. I just given a brief introduction to this. So I would go to the terminologies and I'll just give you a brief introduction about the various terminologies which we are going to discuss during the further of this discussion. So the most common terminology that we've all heard of is SpO2 or the oxygen saturation. What is SpO2? Oxygen saturation is nothing but it's the fraction of the oxygen saturated hemoglobin and relative to the total hemoglobin in the blood. And this human body requires and regulates this in a very precise and specific balance to balance the oxygen in our system. What is a normal saturation? Usually maintain a saturation of more than 94%. So we always make sure it is somewhere between 95 and 100. If there's a we always consider it as anemia, and this is alarming, and we should consider supplemental oxygenation. The next terminology is nothing but PaO2. What is PaO2? We would have seen it in our ABGs or VBGs. The partial pressure of oxygen, also known as PaO2, and it is the measurement of oxygen pressure in the arterial blood. It reflects how well the oxygen is able to move from the lungs into the blood. And when the body is functioning in a normal state, the expected PaO2 is somewhere should be between 75 and 100 millimeters of water at the sea level. The next terminology would be FiO2. What is FiO2? It is a fraction of the inspired concentration in the concentration of oxygen in a particular gas mixture. So what is the normal oxygen concentration in room air? We know it is 21%. So when we start using oxygen devices like nasal prongs, face mask, NRBM mask, we can approximately calculate what is the FiO2 that we are going to supplement to the patient with arbitrary formulas, which will be dealt later by my senior colleagues. Next point is PF ratio. PF ratio is nothing but what we just discussed in the previous two slides. PaO2 by the FiO2 ratio. We easily call it as the PF ratios. Okay, and it is about the ratio between the arterial oxygen partial pressure to the fraction of the inspired oxygen concentration. So I had told you the partial pressure at sea level will be somewhere around 75 to 100, and the normal FiO2 which we inhale, the oxygen concentration in the room air is around 21%. So if you divide 100 divided by 25, somewhere around 500. That is why I have mentioned the PF ratios at sea level. The normal ratio would be somewhere ranging between 400 and 500. So we have a ARDS severity scale, and according to the PF ratios, we can even categorize it as a mild ARDS, moderate ARDS, or a severe ARDS. When you say it is mild, the PF ratios would be somewhere ranging between 200 and 300. And you expect a mortality of somewhere around 27%. And if it is moderate ARDS, we say the PF ratios would be ranging between 100 and 200. And if it is severe ARDS, definitely the PF ratio would be less than 100. I just mean to say if you're giving 100% oxygen, still the PaO2 would be less than 100. That means the PF ratios are less than 100 and the mortality is pretty high, around 45%. So oxygenation is not the only thing. Another important thing which we have to assess when you see a pregnant lady is the work of breathing. Work of breathing is nothing but it is the energy expended to inhale and exhale a breathing gas. In a normal setting, in a resting state, the work of breathing constitutes about 5% of the total body oxygen consumption. And the work of breathing refers to the use of accessory muscles of respiration, the nasal flaring, the abdominal and chest retractions and indrawings, and the depth of the respiration. In this slide, you can see, I just wanted to show you what nasal flaring would be. The use of accessory muscles of respiration like the use of the sternocleidomastoid and even the chest and the abdominal muscle indrawings. You can see all these in this slide. The components which include the work needed to overcome the elastic recoil of the lung and to displace the chest wall and the abdomen as well, the work needed to overcome the airway resistance. There are two things which are very important when it comes to the work of breathing. One is to overcome the elastic recoil, the compliance, and then comes the airway resistance. For example, when we have a restrictive lung disease like an ARDS or something, and then the inspiratory work of breathing is increased because of the decreased lung elasticity, the compliance is reduced. Whereas in an obstructive disease like COPD or asthma, the work of breathing is increased because of the increased airway resistance. Last but not the least, this terminology is very important, PEEP. PEEP is nothing but positive end expiratory pressure. PEEP is actually a mode of therapy which is used in conjunction with mechanical ventilation. So at the end of a mechanical ventilation or a spontaneous exhalation, when a PEEP is kept, it maintains the patient's airway pressure above the atmospheric level by exerting a small pressure that opposes the passive closing of the alveoli. So when we keep a PEEP, we avoid unnecessary closing and opening of the alveoli, which causes athalec trauma. And what are the uses of keeping this PEEP? The use of PEEP in patients with acute lung injury, it actually helps in improving the arterial oxygenation by different ways. So it alleviates pulmonary shunting, it helps in the respiratory muscles to decrease the work of breathing, and it also decreases the rate of infiltrated and atelectatic tissues, and it also increases the functional residual capacity. By all this, we can improve the oxygenation in the patient with an acute lung injury. So I just wanted to emphasize, just by increasing the FiO2, you might not help. You can always increase on the PEEP to achieve all these things and improve the oxygenation of this patient. And with this, I think I just completed my topic. Thank you, sir.
Thank you, Vivek, for putting the foundation for us to understand probably what we are going to discuss now. Now that we understand the importance of the lungs in oxygenation, which all of us I am sure know, the next thing what we thought was from a practical angle, very practical, mundane, because we have to know how to assess the respiratory status or the oxygen saturation status of an individual. The simplest is, of course, to watch a person breathing. And beyond that, there are devices that we can use to know, because sometimes even when the oxygen saturation is not adequate, the person, you may not look as in distress. So my colleagues here will explain to us the common devices that we use to know the oxygen saturation of the person. And can I request Sachin, the simplest of all these, which even the lay people now talk about, and that is a finger pulse oximeter. Okay, can you just explain?
Thank you, Paji sir. Thank you, office bearers of Kfog, for this opportunity. I would like to demonstrate the simplest of the hypoxia detection device. This is called pulse oximeter. I'll stand up. To demonstrate the simplest of this device, this is a pulse oximeter. This device, you might have all seen, this is the simplest type, the finger pulse oximeter. Many a times there we have observed wrong placement of finger pulse oximeter so that the correct saturation is not read, often led to mistreatment of the patient. Now we'll see how does this device work. This device works on a complicated principle called Beer-Lambert law. I'm not going into details of that, but it just tells you there is a light emitting diode. I am sure you will be able to see that. There is a light emitting diode which emits light in two frequencies. One is in the infrared frequency and the other diode emits frequency in the red ray. Okay. Now, when this ray of light passes through the body tissue and reaches a detector on the other side of the pulse oximeter. You go to the camera. Yeah, I'll go to the camera. Then
His sound is not heard. Voice is not heard. Voice. No audio. See, you are requested to repeat everything you said when you came in the front, okay? കാണാനേ ഉള്ളൂ, കേൾക്കാനില്ല. The Rajagiri team, please unmute yourself. Unmute you. Muted ആണ്. Sir, muted ആണ് sir. ഒരു മിനിറ്റ്. ഒരു മിനിറ്റ്. ഒരു മിനിറ്റ്. ഇപ്പൊ ക്ലിയർ ആയി. You are unmute now. Please go ahead. ഇപ്പോഴും അവിടുന്ന് സൗണ്ട് ഔട്ട്പുട്ട് ഇല്ല. No sound output from there. No, no, no. അവിടെ ഇരുന്ന് സംസാരിച്ചപ്പോ കേട്ടതാണ്. അവിടെ ഇരുന്ന് സംസാരിച്ച് നോക്കാൻ പറയൂ. സൗണ്ട് ഔട്ട്പുട്ട് ഇല്ല അവിടുന്ന്. ആ ഇപ്പൊ കേൾക്കണം.
Rajgiri team, please check if your audio device is connected to your computer or laptop. If it's a Bluetooth enabled device, if it's still connected to your laptop or computer.
കേൾക്കുമ്പോ പറയാം. കേൾക്കുമ്പോ പറയാം. ഇല്ല. ഇല്ല. കണക്റ്റഡ് ആണോ? ബ്ലൂടൂത്ത് കണക്ഷൻ ഉണ്ടോ?
Am I audible now? Is it audible now?
Very much correct. Very much audible. Yes.
Okay.
Just want to tell our viewers, I'm sorry, we are sorry for the technical issue. I think some unmuting issue was there. We will start once more. Sorry for the trouble.
Okay. Yeah. So this finger pulse oximeter, most of the time the correct reading does not come because you don't apply it in the right way. Now every pulse oximeter will have a light source and a detector inside, and if the body tissue is not placed properly between the tissue, between the light source and the detector, the reading will not be proper. So the light waves has to pass perpendicularly from the light source into the detector. So if the source is if the light ray is passing in a tangential way, the reading will not be proper. So there are certain troubleshooting. One is you can always see a waveform when we switch on the pulse oximeter along with the pulse, the number heartbeat per minute and the saturation. There is a waveform. If I come closer, the audio will be muted. So any pulse oximeter will show a waveform here. If the waveform is not correct, that means the pulse oximeter reading also may not be correct. Usual waveform will have something similar to an arterial waveform. Arterial waveform, you would all have seen, there will be a dichrotic notch, a peak, a small dichrotic notch and a dip. So the pulse oximeter waveform will also have something similar. So if you have a uniform, a very synchronized waveform, then most likely your reading is correct. If the waveform is not corresponding to the heart rate, or if the waveform is not uniform, or if the peaks are not uniform, the reading is unlikely to be correct. Second is if your patient is having hypotension, or if the peripheral circulation is poor, then again the pulse oximeter reading will not be correct. Hypothermia leads to vasoconstriction, periphery vasoconstriction, and that can lead to erroneous pulse oximeter reading. There can be problems when you apply it in the wrong way. So suppose you apply it in a tangential way. If the finger is not inserted properly, the light rays cannot pass perpendicularly through the body tissue. The reading can be wrong. If the patient is having nail polish of certain colors, like blue, green, black, and colors like that, there can be erroneous reading. Fortunately, red nail polishes are not found to be causing much problem with the reading. Now, how do you know whether the reading is inappropriate or not? You need to have a proper clinical judgment. Always, if the reading is not according to what you expect, you can put the pulse oximeter on your finger and see whether it is a gadget error or is the patient is really having hypoxia.
Okay, okay, Sachin, thank you. And we hear in the media also advising patients who are allowed to stay at home to do the 6 minutes walk test using the pulse oximeter. Can you just explain briefly what they should do and how it helps us?
The 6-minute walk test gives you an indication about the cardiopulmonary reserve of the patient. That is, the patient most of the time, especially in COVID, will not have features of hypoxia. The patient will not have any symptoms. So what we are trying to do is that we are going to exert the patient, make the patient do a little bit of work and see if there is any change in the hypoxia, change in the oxygen, fall in the
okay. So
stage.
how much fall will be significant?
Yeah, there about 4 to 6% fall can be taken as significant. What we do is we do a pulse oximeter reading of the patient, then ask the patient to do normal walking inside the patient's room for 6 minutes. The patient should be wearing normal clothes. The patient should be wearing mask, ordinary surgical mask, and do the 6-minute walk. At the end of 6-minute walk, you do the pulse oximeter testing again and see the value.
So if the value has dropped beyond 3 or 4, then it will be significant. Am I right?
That will be significant.
Okay.
That will be significant.
Now that is the simplest way we can know the oxygen saturation level of the patient. Now in the hospital setting, which most of us are dealing with, there are more sophisticated instruments to use, and one of them is the multi-parameter monitor. Julius, can you tell us briefly about what this multi-parameter monitor, why is it called so, how to apply it, what information we get out of that?
Good evening, everyone. I hope I'm audible. Thank you, Piley sir, as well as everyone from Kfog for this opportunity. In this session, we'll be talking about multi-parameters. So I think you're all familiar with the machine because this is something that you use most often inside a hospital setting. Multi-parameter, as the name suggests, we do not want to use too many gadgets on and off. That is why we have one single monitor to look at all the patient's vitals together on a single screen. So as you can see now in front of us, we are having the multi-parameter monitor. So you will be able to record all your vitals inside this. Your heart rate, your blood pressure, your saturation, your respiratory rate, and you will be able to, if you have modules for arterial blood gas and end-tidal carbon dioxide, you will be able to monitor those as well. So with this monitor, I think all of you will be having different kinds of machines, and you will be knowing basically the knobology, which I'm not going to discuss in too much detail, but certain things that I would like to stress on is first, when you get a patient, the first thing that you should be connecting is a pulse oximeter. Okay, so when you connect the pulse oximeter, as was said now by Dr. Sachin, you have to place it properly so that you will be getting the proper readings. Okay, so as we have seen inside the probe, you will have infrared light coming, which should be mostly kept on the top. Okay, on top of the, Nadish, can you show it inside? So the light should come on top, that is on your nail side, and it should not be directly over the nail, it should be pushed in. So it is passing the nail. Okay, and then when you fix it properly, you will be able to see a waveform on the machine. Okay, you have to wait. Sometimes some machines will take some time, but you will be able to see a proper rhythmic waveform that is coming on the machine, which will, and you will come, and there will be a number that is coming, that is more than 94 in a normal person. Once you see that, you can make sure that the reading is right. Now, most of the time what happens, the usual pitfalls are the probe will not be kept properly, or as we said before, there will be a nail polish, or there will be increased tremors, due to which the machine cannot pick up the pulse or the saturation. So you will be seeing a reduced saturation, and all you will get panicked. So whenever you are getting a low saturation, first make sure that your probe is again kept properly. And once that is kept properly, you have to correlate with the.
Nidish, can you just show where the saturation is shown and the 80 is the pulse rate, isn't it? Heart rate. Yeah.
So the one seen on the bottom, 99 to 100, is the saturation that you can see. Simultaneously, our multi-parameters will also pick up the heart rate, which you can see on the top. That is your
89, 91 now. Okay.
91 is heart rate and 90 is saturation.
Yeah. So other than this, we will be able to get the blood pressure. Next thing that you can connect is the chest leads, which we will also demonstrate. Again, different types of machines will have different types of leads. Our machine usually has 5 leads that we can connect. Some will have 3 also. So how to connect it? Usually it is written on the leads where to connect what. Okay, so you will be having. So it will be indicated with a letter on the leads where to connect. You will be having the, what is this called?
Right hand.
Electrodes. You will have the electrodes, which you can. It's an adhesive that you can put on the chest of the patient, and once you keep it, you can attach the leads onto the electrodes. So first, according to our monitor, we can connect the red one that is written right on the right side of the chest. I hope it is clear for everyone. Yeah. Okay, so the second chest lead, second electrode you can connect to the left side. Yeah.
Zoom, please.
So I'm not going to specify much on the colors here, because in certain machines, again, in 3 leads the colors will be different, in 5 it will be different. So you need to know your machine before you use them. So it will always be written on top of the leads where to connect which. So we can connect the third one to the right side lower, and the one is on the center of the chest. Yeah. So the both that are attached down is usually going down onto the legs. We are putting it here downwards so that it can be an indicator, and the center was in the chest. So when you connect all these to get the leads, you will be able to get the ECG rhythm on the monitor, which will help you to identify any rhythm related changes as well. The last thing that we can see is the NIBP, that is a non-invasive BP measuring, which we usually do with the normal BP cuff. This you can connect it onto the monitor. We are not going to demonstrate it much. It is usually connected as we do it on a normal BP cuff as well. But here again, one more thing that you have to do is, whenever you connect it, you need to make sure the time that you need to keep the BP reading. Sometimes it will be kept at 5 or it will be kept at 10. Usually there is no point in doing a 5-minute BP all the time, because it is usually painful for the patient and inconvenient as well. So you need to set the time. That is also of prime importance when we use these measures. When we use these machines. Thank you.
Thank you, Julius. Now that we have identified if there is a problem with the oxygen saturation, and if you want to give oxygen, the therapy part of it, what are the measures or methods available? That's what we are going to consider now. Sachin, if you could tell us what from a probably an ascending order of from simple to the most difficult one, because the whole aim is to give oxygen, and what's the simplest device that we can think of?
The simplest and the most commonly used one um, we use in our setup is the nasal prongs. So the nasal prongs has a lot of advantages. One is it is very cheap. Second, it is very comfortable for the patient. The patient can talk, eat, do most of the normal routine activities with the nasal prong on. Now we'll show you how the nasal prong looks like. You all will be familiar with the nasal prong. There are two nasal limbs for the nasal prong, which has to go inside the two nostrils.
Apply, show it applied here, Alan. Yeah.
There is a retainer strand for the nasal prong that has to go behind the head, that will keep the nasal prong fixed in place. Now, the most important aspect you have to keep in mind when you're applying a nasal prong is the flow rate has to be kept between 2 to 4 liters. More than 4 liters of flow rate in the nasal prong can lead to problems with the nasal mucosa. There can be crusting, there can be damage to the mucosa. The FiO2 you can achieve by keeping a nasal prong is from 0.28 to 0.38 percent, because there is a rough calculation on the FiO2. It is calculated with the formula 21 plus flow rate into 4. 21 being the FiO2 of atmospheric air. So according to variation in the flow rate, you can increase the FiO2, but FiO2 will not increase if you keep the flow rate more than 6 liters per minute. So this has to be borne in mind when you are using a nasal prong. So up to 0.38 or something is what maximally you can achieve with a nasal prong. You cannot achieve more than. So any patient who requires oxygenation FiO2 more than this will have to go with a better device, that is face masks, a simple
Can
face
you just
mask.
show us how the face mask is used, and then
Simple face mask.
Yeah, can you just show, Alan, if you could show the face mask? That's a simple face mask, and you can probably connect it to the source itself.
Alan, can you show the simple face mask? The simple face mask has about 100 ml of reservoir space. It has expiratory port. There are a few holes on each side, and in the middle there is a point of entry for oxygen. So usually what happens is that fresh oxygen will enter through the center part of the face mask, and when the patient breathes out, the expiratory air that comes out of the patient's nose will exit through the expiratory holes that is kept on the sides. So what happens if we are not providing adequate flow of oxygen, the patient will start rebreathing his own expired oxygen, expired gases, mostly carbon dioxide. So a minimum flow of more than 2 liters has to be kept at any point of time in a face mask. So sometimes we often see face mask being kept with about 1 liter flow. We are not doing any good to the patient. We are only allowing the patient to rebreathe his own expired gases with that. Now,
can you show how it is applied actually? Yeah.
The face mask has to be applied using most of the face mask will have an inbuilt elastic band that is used to retain the face mask. It has to be applied in a tight fashion. Alan, can you demonstrate how to apply it properly without any, yeah, you can adjust it. So we should take it like this. Just treat the patient's nose first and put the tie back to the head. And if you want to adjust the tightness, you pull the elastic strands and keep it tight.
And can you just show where the oxygen is connected, please? Yes. Okay. Yeah. Now, Alan, I see that the mask is projecting beyond the mandible down there. Is that okay, or no, this is a bit too big for this
Yeah,
patient?
this is
All right,
bit-
that's the
this
problem.
is
So
the
there should not be
problem.
any gap there, isn't it?
Yes, yes,
Okay,
sir.
that's important. Okay.
Now, you have to keep in mind that the maximum FiO2 you can achieve with a face mask is 0.4 or 40%. Other than that, even if you increase the flow rate, you are not going to achieve anything. So, if the patient is not getting any better with even at 8 liters of oxygen, you need to think of something different. Now, the next device we have is a non-rebreathing mask. Now, non-rebreathing mask was once the best method to provide FiO2 almost similar to an intubated patient. Almost up to 95% of FiO2 can be achieved with a properly placed non-rebreathing mask. Now, what makes this mask different is a huge bag, that is a reservoir bag, and valves placed strategically at different location. These are all one-way unidirectional valve. There is a valve that prevents rebreathing. Now, I told you, normal face mask, there is a chance the patient can rebreathe his own carbon dioxide, his own expired gases. But in non-rebreathing mask, you can see a valve right in the middle that prevents expired gases from entering the reservoir space and the patient rebreathing that. Now, we'll connect this rebreathing mask and demonstrate how to put it properly. The most important thing you have to remember is make sure the bag is full before you apply it on the patient. How do you fill it? You apply a little pressure on the unidirectional valve, close the valve and start oxygen. The bag will get full. Now the bag is full, you can apply it to the patient like you apply a normal face mask, and you have to make sure it is applied, it should be tightly fitting. Snugly fitting, there should not be any leak. And you have to keep a flow rate of 10 to 15 liters to achieve the full functional capacity of the normal and non-rebreathing mask.
Can we just, for the camera, can you focus onto the cylinder? Can you focus that, yeah, bring it to the center, please. Yeah. Can show that, can you lift it up a little bit, actually?
The flow
You
rate.
can lift it up a little bit. No, I just wanted to show that this is coming through a bottle with the humidifier water there, and this is the commonest source of oxygen that we used to have everywhere. Now, of course, now these days we have got more hospitals with piped oxygen, but this air the oxygen that is coming through that water is important that it humidifies it, isn't it? But is there anything that we have to be careful about in that maintenance of that bottle and the water? How often do you have to change it? Do you have to change it at all, or we can wait till it dries up? Yeah.
Daily we need to change the water.
Daily?
Yeah.
Okay.
And it is
what sort of
important.
water do you use there, if you can move in?
So it's sterile water.
Sit down, sit down, sit down. Sit down? Yes.
It's sterile water that is being used, and it is important to provide humidity when you are giving a gas. So the humidifier is used for providing humidity. And the water that is used is sterile water, and daily you need to change them.
It has to be changed daily.
Yeah,
Okay,
yeah,
so that's very important, because especially these days with the mucormycosis, there is a concern that whether improperly maintained humidifier can be a reservoir for the fungus. Okay, thank you, Della. Can we move on in case the non-rebreathing bag or mask doesn't help and you have to give a little more? What is the next one available for us?
So I think we are now showing how the escalation matrix in oxygenation also is there. The low flow device and the high flow device. Now we have done with three important things: the nasal prongs, the O2 mask, and the non-rebreathing mask. Suppose the patient is still hypoxic, especially if the patient has got an increased work of breathing and he is tachypneic, then all these measures may not work. You need to provide some sort of an extra measure. That is what our next gadget comes in place, which is called as the HFNO. And you all know that HFNO has definitely revolutionized treatment in respiratory failure, especially in COVID. People call it as HFNO or HFNC, both are same, high flow nasal oxygen or high flow nasal cannula. We will have a practical and a theory demonstration of how do you use HFNC.
Good evening, everyone. Hope all are in good health. Moving on to the next topic, high flow nasal oxygen or nasal cannula. So the difference between the high flow nasal cannula from the other oxygen devices is that it provides a flow rate that is more than or exceeds the patient's spontaneous inspiratory effort. So since now we are discussing on low flow devices. So high flow devices is something that provide a flow rate that is more than patient inspiratory effort. So when comparing to a face mask, high flow nasal cannula or oxygen provide oxygen that we are delivering as fixed. In HFNO, the oxygen is being provided in a fixed manner, whereas in nasal cannula and face mask, the oxygen that is being provided is variable. So it is believed to improve the HFNC machine, provide a heat and humidification, like we will have a demonstration in the same. And as I already mentioned, the inspiratory flow that is being delivered is more. And okay, when you're increasing the flow rate, it's believed that when you're increasing the flow rate with 5 liters per minute, 1 centimeters of PEEP is being provided. And as I already mentioned, the oxygen delivery is fixed with HFNO and it helps in washout of dead space. So the key benefit is with providing an optimal humidity, we are giving a mucociliary clearance and patient comfort. And with adequate flow, we are getting an accurate oxygen delivery and washout of anatomical dead space and a low level of PEEP. So the basic components include a flow generator, air oxygen blender and a humidifier. Okay, now my colleague Alan will demonstrate the machine.
Okay. Just want to clarify certain important points is that, mind it, we are giving a device which is definitely going to give you a inspiratory flow which will help the patient to make the breathing feel better. Second point is that we can always give a small PEEP which will make the oxygenation also better. Maximum PEEP we can give is 5 with a flow, with a HFNC. And the demonstration will happen right now. Please watch it.
Evening to all. First of all, let me just show the main components of the HFNC machine.
Main screen. Okay.
So the main components of the HFNC machine is, first of all, this is the device, and this is the oxygen which we are using to connect to the oxygen pendant, and we have an oxygen flow meter, and the other main equipments are the circuit which we use for the connection. Also, we have a chamber which is used for the humidification, and the main part is the cannula, the HFNC cannula, which we use the patient side. So the connection goes like, we have to connect the chamber, part over here, and for the continuous humidification we use this sterile water, and we just connect and hook it up to the machine stand. And the next one is the circuit. We connect the circuit to here. Also, in order to give the oxygen, we have to connect a simple oxygen tube to the flow meter and to the device. This is part where we connect the simple O2 tube. And this is a cannula part where we connect to the circuit. And this is the cannula. And to connect to the patient, first of all, just explain to the patient why you are keeping the machine. And to initiate, as we keep the same as the nasal prongs and the simple face mask, we just keep it. And in order to adjust the tightness, we have a clip over here, so we can pull it. And this is how we initiate the HFNC.
Okay, now that we have the different devices that will deliver oxygen, but we can reach a stage where even this is not enough, isn't it?
Yes, sir.
What is the next available?
I think before I go into the next device, let me remind the audience of a couple of important points with high flow nasal cannula. All these non-invasive devices, the success depends upon the patient's cooperation. We need to explain and tell them to be wary of what is the initial effect, and then the results will come. Now, high flow nasal cannula, for the kind of information, this particular thing can give a flow rate of 60 liters and an FiO2 of 90%. So you need to go up on the flow rate to 60 to make the patient comfort, and then FiO2. And you monitor the ABGs, humidification is happening. Now, another tip is that probably you need to ask the patient to keep the mouth closed, because opening the mouth can reduce the effect of PEEP or the positive pressure what the patient is about to get. The second point is that whenever you're using HFNC, make it a point that you ask when you're planning to come down, you reduce the FiO2 first slowly and then reduce the flow rate. So the flow and the FiO2 are the two settings which you put in the which you going to adjust in the HFNC. The last point, there's a data currently which has come that a surgical mask wearing on top of the HFNC, your surgical mask can increase the efficacy. There's a paper which has come which can also increase. Now, suppose HFNC is not there, HFNC is failing, or the patient is getting more respiratory excursions, getting tachypneic, we have the next device, what we are called as a non-invasive ventilation or the NIV.
So can I just ask you, Jacob, that means can be used only in a conscious patient?
All non-invasive ventilation, a normal conscious level HFNC or NIV is important. Now mind it that if there is an hypoxic encephalopathy, low GCS, conscious level is low, and if the patient is severely, excursions are high, then you need to go in for an invasive ventilation. Consciousness, pure good GCS and patient cooperation is important for the success of non-invasive devices.
Okay, thank you. Now we are going to see the NIV, is it?
NIV.
Is that this side?
Yeah.
Okay, so I hope everybody can see the screen. So we are going to discuss about non-invasive ventilation, and on the screen you will be able to see different types of non-invasive ventilator machines that are being used all over the world. You have one that covers only a nose, one that covers the nose and the mouth, one that covers the face as it is, and as a head as a whole. Okay, so no matter whatever you use, the aim of non-invasive ventilator or using a non-invasive ventilator is proper ventilation. So till now we were discussing about low flow devices in which equipments or oxygen were delivered in order to increase the oxygen levels inside your body. Okay, so here what we lack is, or what the patient is, or has the respiratory distress he is in, is because the oxygen carbon dioxide exchange is not happening in his body. Basically the ventilation is not happening. So now we have to step up our strategy from just oxygenating the patient to ventilating the patient now. So ventilation means, again, the primary aim is to provide oxygen. Second is to help the patient breathe. Okay, so first is we need to support the patient's respiratory muscles. We have to reduce the fatigue of his lungs. We need all the shutdown alveoli to open. This is the main, some of the main functions of a non-invasive ventilator. So its usefulness, as I said, it helps to increase the oxygen. It helps to it supports the respiratory muscles and reduces the effort of breathing. Indications to use an NIV is basically in type 1 and type 2 respiratory failure. So type 1 and type 2, it is pretty easily distinguishable, but you need to have a blood gas machine. Okay, so if you know the PCO2 levels, the carbon dioxide level, respiratory failure, as it says, is hypoxia. The body doesn't have enough oxygen inside the blood. So type 1 respiratory failure is only the lack of oxygen inside the blood. Whereas after some time, when your oxygenation doesn't happen properly and your muscles get fatigued, the carbon dioxide washout does not happen and the patient progresses from type 1 to type 2 respiratory failure. So when you look at a blood gas and you see that the carbon dioxide level is high, that means the patient is in a respiratory failure. Now if you don't even have a blood gas, you can have certain parameters or clinical signs you can get from the patient, like the patient gets confused or the patient is having a high bounding pulse. So all these indicators will say that there is CO2 narcosis or carbon dioxide is building inside the body. So that is a time for you to step up your strategy. Contraindication, as we said right now, patients who do not tolerate non-invasive ventilators, there is no point in using an NIV. So the patient should be fully conscious. They should be able to breathe by themselves. They need to protect their airway. As the pressure from the ventilator comes in and goes out, they should be able to breathe synchronously with the machine. Then only this machine is going to be helpful. Otherwise, the patient is going to definitely go into an invasive ventilation. Again, another contraindication is hemodynamic instability, as we discussed initially regarding the PEEP. When you increase the PEEP, what happens? Your cardiac output goes low, and then there is high chance for your blood pressure to go down, or you can end up in hypotension. So if the patient is already hypotensive, NIV is again not indicated in such kind of patients. So again, I would like to again emphasize on this statement: only use NIV for a patient who cooperates. Otherwise, do not use, because ultimately you will be ending up in an intubation or an invasive airway. So NIVs are basically, you have two types. One is your BiPAP. It is called bilevel positive airway pressure. It is again delivered by a tight fitting mask, but the ventilator delivers the inspiratory pressure as well as the expiratory. So there is a pressure from the machine into your lungs as well as it sucks it out. There are two pressures that are happening here, and the good thing about this is we can be able to control these both pressures. So usual settings that everybody can start for a normal person is the expiratory pressure, you can keep it at 4 to 6, and the inspiratory pressure you can always keep it at 10 to 12. You can start from there and you can go and you can escalate according to patient's response. And BiPAP, as it is, because we need to control the oxygen and carbon dioxide, it is usually used in type 2 respiratory failures where the carbon dioxide levels are high. CPAP is another form of NIV. Again, here the aim is, as I said, to splint open the airways. All the small terminal bronchioles and the alveoli that are collapsed need to open up, and then only the surface area will increase so as to increase the oxygen carbon dioxide exchange. So what it will do is, whatever is collapsed, it will open up. Whatever is opened, because of the pressure, it will splint it and keep it open, and it will add more alveoli. All those dormant alveoli that is there, it will open up, and that will help in effective oxygen carbon dioxide exchange. Again, CPAP is similar to the EPAP on the BiPAP. So we can start at 4 to 6 centimeter of water and escalate according to patient response. Parameter settings is just a highlight. Whenever you are, these are some parameters that you will be able to set on the machine. The tidal volume usually you keep 6 ml per kg. And so if it is a 60 kilogram person, you can use 360. The FiO2 again you have to taper according to reach a saturation of 94. As we discussed in the earlier lectures, FiO2 is different for depends upon the patient's need of oxygen. 21% we get from the air, and the rest has to be supplemented by these machines. So we can keep on supplementing them. Our aim is to reach a saturation of 94%. IPAP, EPAP 10 by 5, that is a usual setting that we usually start with. Now, if you want to regulate the carbon dioxide, that is you initially start at 10.5 and then you take a blood gas after 20 minutes, you see that the carbon dioxide level is still high, but your oxygenation is improving. You can just increase the inspiratory pressure by 2 centimeters. So you can escalate IPAP only to 2. Now after an hour, if you see that the oxygen and carbon dioxide both are not improving, then you can increase the IPAP and EPAP by 2 centimeters. So this you can regulate till the patient's oxygen level reaches more than 60 in PaO2 and your carbon dioxide falls between 35 to 45. Complications anticipated with NIV, as I said initially, because of increased thoracic pressure, your cardiac output will go low and your BP will fall. So do not use it on hypotensive patients, and always be or you should always keep on monitoring the blood pressure for patients on NIV. Reduced effectiveness. If the patient is not able to tolerate the machine, you should probably think of an early intubation. When you keep NIV for a long time, obviously you cannot eat or the patient cannot eat and drink. So fluid and balanced nutrition has to be looked on properly. Another important complication of using NIV is skin necrosis. The mask that you are going to use is going to cause skin necrosis on the face. So you have certain gels that are available. You can put it on so that that complication can be taken care of. And barotrauma. If the pressure that you are giving is too much for the patient's lungs, there is a chance that you can develop a pneumothorax or a pneumomediastinum. So when you give too much of pressure, what happens is all the small alveoli, they tend to have micro ruptures, and the air can leak into your mediastinum, causing air to go around the heart as well as the lungs. So these are certain complications that you need to keep in mind. While the patient is on an NIV, you should monitor certain things. First is the conscious level. If you feel that the patient's conscious level is going down, he's sleeping, he's dozing off, that means the carbon dioxide is building up. So then you have to again step up the strategy. You need to go to an invasive ventilation as soon as possible. Blood pressure should be monitored because NIV has the potential to cause hypotension. Pooling of secretions is another thing, again can give way to a lot of infections. And the next point is very important. Before starting any NIV, you need to counsel the patient. You need to tell them that this machine is going to do this. It's going to give a pressure inside. It's going to take some pressure out. So when that pressure is coming in, you need to breathe in and you need to breathe out with the machine. Because if it is not done properly, then there will be no point of starting an NIV. And as you should avoid any sedatives while the patient is on NIV. Thank you.
Thank you, Julius. Can we have some of these machines demonstrated now?
By the time machine is getting ready, there's a couple of questions have come about utility of NIV in COVID pneumonia. Let me put across one thing very clearly. Non-invasive devices, non-invasive ventilation, especially non-invasive ventilation, NIV, the monitoring and the usage is much more difficult than an invasive ventilation. Because invasive ventilation, you have a control of things. Non-invasive ventilation, your control is important, patient's cooperation also is important, and each and every patient needs to be monitored aggressively for a eventuality. Because NIV failure, crash intubations can be a real dangerous thing. So the COVID pneumonia, NIV, yes, it is being used. However, it has been used with a caution, especially in a pregnant patient. Some guidelines do say that HFNC failure, you go out and put an invasive ventilation. However, we know that our challenges in invasive ventilation in a COVID pneumonia, especially in our setup and in a pregnant patient. So a cautious trial of NIV is important. Monitor the patient's response by monitoring the oxygenation and carbon dioxide especially. And another important thing to monitor is the patient's work of breathing, respiratory mechanics. That is bad if the PF ratio, the PA to FA2 ratio is coming less than 150 despite being in non-invasive ventilation. That's a time maybe you have to think of advancing to an invasive ventilation. Cautious trial of NIV is always warranted. Now we will demonstrate certain things. Now it is important that you will have two types of NIV machines available in the hospital. One is the classical simple thing what all of us must have seen, which is a smaller device which is called as the machine. The machine, which is called the different companies come with that. This is an NIV machine. What you can see over here. Now, if you ask me, close it. If you ask me, can you use this machine in a COVID pneumonia? Yes, you can use, but the problem is that there is no, you cannot fit a viral filter to it, and the aerosols what the patient generate comes from the expiratory valve over here, so that in the mask itself, so that the aerosol risk of healthcare workers is very high. And you can see over here, there should be an inspiration, there should be an expiration. The wire, the connector wire gives the inspiratory thing over there. But the expiration happens through the mask which is vented. There is an opening there. Whereas in the NIV mask which is connected to the ventilator NIV, it is not vented. Whereas the smaller machine, it is vented. And through the vent, the aerosol comes out from the patient, which can be infectious. That is why the smaller machines are not advisable in a pandemic situation because of the risk of healthcare infections. Now, all of us have this particular machine, what is there, which is called as a ventilator. And this can be used as a non-invasive ventilation also. But certain things are important because it is important that I know gynecologists, obstetricians may not be used, but these are all practical tips which we like to give that. One of the important thing is that it is important that you should change the mode in the machine to an NIV mode, because there is a button over there which you keep to make it every machine is same, which you keep the machine on and off. Then there will be, when you turn back, there will be a screen which you can see the machine is getting on. And once the machine is on, the machine will ask whether it is an NIV mode or a tube mode. You can see over here, the tube mode or NIV mode. That is a tube is endotracheal tube, NIV is a NIV mode. Because both have got slightly different mechanism in the machine. It is important to select that, number one. Number two, it is same like a ventilator where there is an expiratory limb and an inspiratory limb. Inspiratory limb gets the oxygen, gets the air inside, expiratory limb gets the air outside. In a COVID pneumonia, practical point is that filters are available. It is important to put a filter in the expiratory limb so that it can act as a viral filter which you attach over there. And when you initiate an NIV, it is very important that the patient cooperation is important. Now explain to the patient that we are going to have a gas coming through the mouth and then it's going to be tight on your face. Please bear with us, take normal breath couple of times and then you will be used to it. And this is the mask which is seen over there. If you ask me what is the difference between the mask shown before and the mask shown now, is that there is no venting, there is no gap or holes in this mask, because in this ventilator the expiratory gas goes out through the ventilator itself. There is a circuit is there, the circuit, two limb circuit, one is the inspiratory, one is the expiratory, that takes out the gas. So the aerosol risk for healthcare workers is less because we have a filter at the expiratory port. And this mask, like any other patient, if you put it in the mouth and put a air pressure over there, you are going to get claustrophobic. So my advice to all of you who is initiating is that you ask the patient to hold the mask. Feel it. You have some time for that. And ask them to keep the mouth slowly. Don't keep it closed. Don't attach a strap over here. Attaching strap with the air pressure coming, I have experienced myself, it is terrible. Now start the flow slowly. very slowly, as Julius has mentioned, whether it is a machine or the BiPAP machine, we have two pressures basically to do it. One is the IPAP and EPAP, whereas in a ventilator, we have the pressure support and the PEEP. Simple terms, I'm just putting it. Start with the smaller one, 6 of pressure support, 4 of PEEP or 5 of PEEP, and then make the patient feel it by not attaching the strap immediately. Slowly let the patient get the air in and get the confidence up, because patient confidence, patient cooperation is important for NIV success. And while you are keeping the mask, what you are monitoring is that how the patient's breathing is there. They will be tachypneic, respiratory of 40, 45. You are keeping the mask over here. You put a pressure 5, pressure support of 6 by 5. That's what or 8 by 5 or 10 by 5. Now slowly increase the pressure support 8, 10, 12, 14 depending upon the patient's respiratory rate and the way the patient is breathing till you reach a comfort level. Oxygenation, remember, oxygenation is one thing, ventilation is second thing. Oxygenation you can adjust in the machine because FiO2 can adjust 21 to 70, 80, whatever you want to get a saturation of 90 to 96, what we aim for in a pregnant patient. However, the ventilation part is important. By this pressures adjustment, you get the ventilation correct, which makes the patient comfortable. One more important thing is that on keeping NIV, you have to have the monitoring of the blood pressure because sudden blood pressure variation can happen. Number 2, oxygenation definitely you will measure. After 1 hour, do an ABG. ABG, look at the oxygenation and carbon dioxide. Both are important. Carbon dioxide going up is a sign of NIV failure. So it is important to monitor the NIV continuously and then decide upon the success. Every 2 hours or 3 hours, this patient needs to be monitored. You don't need an ABG all the time. However, you need to monitor it frequently, look at the patient clinically, and then assess the success or failure.
Thank you, Jacob. And we want to show Nilesh how to apply that and prevent the skin trauma that can happen. The strap, how to apply it and all that. Because this is now more commonly used in the obstetric wards, isn't it?
Yes, yes.
Yeah. So if you could just give those tips, how to avoid the skin trauma, how much is the appropriate pressure at which or the tightness at which to apply it and all that.
Thank you, Dr. Raji. So this is called a deodor, which helps us to prevent the skin peel. This usually happens over the forehead and the and this both are two pressure spots where usually the skin peels happen. So we usually cut it to the shape which is comfortable for the patient. So we put one over here and one over here. And this is a strap which we use to initiate the NIV mask. So we should keep it. We usually keep it at the back of the head. And as Dr. Julius and Dr. Jacob told, we should explain to the patient why they are keeping the mask. And by initiating, we should start the ventilation and initiate the mask to the face. And this is where we connect the strap. This is how we connect the mask, and usually there will be leak through this part, and we should also check for no leak. While we are connecting the ventilator, we shouldn't have any leak through the mask. So then only the patient will get adequate tidal cooling and all that. And this is where we connect the patient circuit. This is the end for the patient side. And we start the ventilation. This is the HME in order to give humidification. Either we can give a passive one or an active one.
Okay, thank you very much. In case this doesn't work, our next step is to have invasive ventilation. Am I right, Jacob?
Yes, when you come to the escalation matrix, I think my advice to all my colleagues who are listening is that if the patient is on NIV support, if you are a unit who needs some help for invasive ventilation, a call and a preparation should be done for getting ready for an invasive ventilation or an intubation, because the main aim should be avoid a crash ventilation. So my suggestion is that suppose a pregnant patient is in your unit with a non-invasive ventilation. Evening before everybody leaves the hospital, you can have an assessment and see that whether any eventuality can happen. Of course, we can't predict everything. My point is that avoiding a crash scenario is always important in a COVID. For one reason, healthcare risk. Second thing, mortality will be high in a pregnant patient, especially when you have a crash intubation. So monitoring and planning things is important. When the patient is on NIV, make it a point that a crash cart or intubation trolley is kept ready so that in case you need that. And for an invasive ventilation, suppose that you put an NIV, 4 hours of NIV, patient still continues to be having respiratory distress. Respiratory rate is more than 40. Oxygenation is around 90 with 100% FiO2. PF ratio less than 100. 3 parameters you have seen. No NIV success is seen despite optimization. That is the time you need to consider an invasive ventilation. Mind the point, if I am a intensive care doctor who has reasonable training in intubation. However, if you ask me, I would like to call the most experienced person in my hospital, if possible, for intubating a pregnant COVID patient. So Sachin and Dr. Vivek, the two anesthetists over here, we would like to listen from them. What are the challenges you expect when you're intubating a pregnant COVID-19 patient?
So,
I will set the setting for that. In fact, in our state, there were 2 maternal deaths due to cardiac arrest that happened on attempting intubations. So that is why we want you to emphasize on the importance of taking precautions when trying to intubate. Okay, please go ahead.
Dr. Jacob is challenging us almost every day. When we get a call for an intubation for a COVID patient in COVID ICU, we know that the trouble awaits us. But now we are far better than what we were 1 year back when we used to get calls from Dr. Jacob. Now, the most important thing here is the safety of the healthcare provider as well as the patient. Now, the patient has COVID. Intubation is a high aerosol generating procedure. So, we need to protect our healthcare worker from getting the aerosol and getting the disease himself. Now, this is where the importance of the intubation done by the most experienced personnel comes. Because normally, we anesthesiologists take pride in saying that the optimal time for an intubation should not be more than 15 seconds. But this may not always be possible, especially in a COVID scenario. But always, the faster intubation, the lesser aerosol that is generated, and the lesser risk of exposure. So first thing, always try and get the most experienced personnel. This is not a job for the residents to try it out. Now, pregnancy, as you know, itself poses a great challenge when it comes to management of airway. As Dr. Vivek mentioned in his presentation before, in a COVID patient, along with the airway challenges, we are dealing with a patient who is going to desaturate the moment we take out the oxygen supply from her. So a few of the patients whom we had to intubate were having a saturation of only about 85 or 86 with NIV. The moment we took off the non-invasive ventilator mask, the saturation plummeted down. Luckily, we were able to put in the tube and restart ventilation before catastrophe started. But one strategy we can do is having the HFNC continued along with intubation.
We can maintain a higher FiO2.
A little louder.
We can maintain a more higher FiO2 and try maximum to keep the oxygen levels in the body higher.
So we will be able to buy some time even if the initial attempts of intubation fails. we can prevent the patient going into a critical level of desaturation.
Yes, we can increase the oxygen reserves in the lung by increasing the FiO2, keeping the HFNC.
Okay, then Jacob, you are going to tell us about the invasive type of ventilation that you are going to do.
Thank you, experts. Before I go into that invasive, we just forgot to mention one important term which has come up in COVID called as PCL. You know what is PCL means? Patient self-induced lung injury, which is an important concept in patients who is on non-invasive ventilation. Like, can you explain what is that PCL and tell us the importance? So when I ask, what did I ask? Always tell you when a patient is on NIV support. Certain points we always mention to you, be careful about NIV. So what is PCL and what are the important steps you monitor in a patient with NIV? We just forgot to mention that point. Can you tell us?
Yeah, PCL is patient self-induced lung injury. So whenever you're keeping NIV, you should maintain the exhale tidal volume. So whenever you are increasing the pressure or the IPAP, make sure that the tidal volume, that is the exhale tidal volume, is always less than 450 ml. More volume you are giving means you're injuring the lung. So volutrauma or barotrauma in the form of pneumomediastinum or some cutaneous emphysema can occur. So the one thing is you need to maintain the exhale tidal volume, and the next one is make sure that you are not just giving the NIV throughout the day. Intermittent NIV can be useful.
Okay, that is another important thing because NIV is something which is tolerance is important. And pneumomediastinum, which as CT I have shown you, Dr. Julius has mentioned about that the incidence of pneumomediastinum is very high in the current COVID ARDS or COVID pneumonia. So beware of the fact of patient self-induced lung injury. Make it a point that the pressures, the pressure support or the IPAP, whichever machine you are using, is adjusted accordingly. And in the ventilator, you can have the tidal volume alarm is there, tidal volume parameter is there. It should be 6 ml per kg, that is maximum 400 ml. If it is going more than that, please reduce the pressure support so that you are maintaining it so that you avoid a lung injury. And avoiding a PCL, avoiding a pneumomediastinum. Second point, breaks. Now, what to break? Sometimes in the early stage of pandemic, we used to give a break to high flow nasal cannula, HFNC. Now we cannot afford to have 2 devices for one patient because of the lack of resource constraints. So a non-repeating mask in between after 2-3 hours of NIV is always an important gadget to have a gap so that we can reduce the lung injury. Now we come to the next point, invasive ventilation. I'm not going to tell everything about invasive ventilation right now. However, certain points are very important because anesthetist intubated the patient and you put the patient on ventilator. Which mode you select, what parameters you set, what are you worried about in the night if you want to give a call, why should you be worried about? Certain few points I will tell it in under 5 minutes. Now, for anybody who is a beginner in ventilator, it is important that when you start an invasive ventilation, the first thing is to select which mode. Now, a simple classical modes which is there in each and every ventilator, even on the name changes, is we have the volume control, you have the pressure control, you have the synchronized intermittent mandatory SIME and pressure support. This is a basic mode which I learned in my early days. All the other modes, advanced modes, mixed modes, dual modes, are all people who knows a little bit more than that. However, for a COVID pneumonia, for a COVID ARDS, for a pregnant COVID, the best mode is that you make a volume control mode. What is that important is that larger tidal volume, we mentioned over there, larger tidal volume can cause trouble with the lungs, it causes lung injury. Ventilator can cause harm. Remember that. Ventilator-induced lung injury, PCL are the terms which has to be aware of. Ventilator can cause trouble to the patient's lung, it can make the ARDS progress. It is your responsibility to limit the injury to the lungs. So, a volume control is important if it is possible because we are controlling the tidal volume to a desired level which is good for that particular patient. You don't need more than that so that lung is not injured. So, a volume, set volume, how much volume is set? A classical example what we all follow is at 6 milliliter per kg. It is not your entire body weight you are calculating because body weight 100 kg person, 600 ml is not correct. You go by what is called as a ideal body weight. The formula is available in the net. You go by patient's height and 6 ml per kg is the tidal volume you set for any patient you are intubating in your ICU. The COVID pneumonia or non-COVID pneumonia especially. The second thing is that your respiratory rate. Now, rate is set if the patient is sedated, paralyzed, whatever rate you have set, patient will get that. Suppose you set a rate of 20. 60 minutes is there. Every 5 seconds, the ventilator will give a breath. So 20 in 1 minute, the patient will get. Now the patient can take the breath. Yes, patient is out of paralysis. It will take the breath. He or she will take the breath. This breath will be supported by the settings you have put for the patient. The third thing is that the PEEP. I think Dr. Vivek has explained about the importance of PEEP. The alveoli closes and opens. In a destroyed alveoli, in an ARDS lung, in a pneumonic lung, the surfactant is not there. So alveoli remains closed. So we need to make it open. That is why we use the PEEP. FI of PEEP is important, basic PEEP. In case the patient is hypoxic, you go upon the PEEP depending upon the oxygen levels. So sometimes we use 8, 10, 10, 15, which is purely something which an expert or experienced person can handle it. So a minimum PEEP has to be set in the initial setting. FiO2, the starting FiO2 is always 100%. You come down on the FiO2 slowly because based on the patient's saturation or the APG PPO2. And certain things which beyond that, maybe beyond the scope of this lecture. However, Vivek, you want to add anything from what I have told?
No, I can just illustrate.
Yeah, just we'll demonstrate in the ventilator these modes in a very quick way. Okay. Dr. Vivek and Dr. Alan will demonstrate that. Yeah.
Thank you, Dr. Okay, so here. Yeah. So we have a Dragon machine here. So in each machine there are different setups, there are different modes, but basically I'm just gonna explain you two major modes. That is, one is the volume control mode and the other one is a pressure control mode. Okay, so I've put this machine in a volume control mode at rest. So the first thing which we have to check is the tidal volume. As Dr. Jacob Suraj told us, we almost set a tidal volume of approximately 6 ml per kg. For example, if the patient's body weight is somewhere around 60, so 6, 6 or 36, so we can fix a tidal volume of approximately 360 tidal volume. The next thing which we can fix on is the respiratory rate. What rate we should give the breaths. So we have a button here to adjust the respiratory rate. We can go down and we can go up and we can fix it somewhere around 15 or 16 accordingly. Then comes the oxygenation. That is the FiO2. I had already mentioned it in my slides earlier. This shows the FiO2 and you can start off with 100% and slowly you can come down. You can come down and the least FiO2 that you can give on this ventilator is somewhere around 21%. But we don't go down to 21. For a safer bet, we always keep it somewhere around 40%. But when you come down, you should come down very slowly, making sure the oxygenation is good enough. The other important thing which I mentioned in the last slide which I meant was about the PEEP. So you start off with a basic PEEP of 5 and then according to the oxygenation you can go up on the PEEP. Okay, so these are the major entities which we have to correct and we have to set in this mode. And also there is one thing which I forgot to mention. This is the inspiratory IE ratio, okay, which we can adjust here. Normally we fix the IE ratio 1:2, but depending on the oxygenation and the ventilation problems, we have to adjust the IE ratio accordingly. So that is all about the volume control ventilation. I just explained to you what is pressure control ventilation. Here now there is a difference. The volume is not the control. Now we are controlling the pressures. This is the pressures. Okay, so if we can fix a pressure accordingly and we can change the settings. This is the only difference between the pressure control and the volume control. Earlier in the volume control, the volume is definite and that is set. Here the pressure is the control limit and you cannot go upon the pressures. In such a pressure we can almost tally with the tidal volumes that we can be giving to this patient. All other settings are almost the same. The extra entity which has come up here is the pressure support. And there is one more mode which we can use is a SIMB mode, which is also would be familiar to many of you. It is synchronized intermittent mandatory ventilation. Here, it is a type of volume control mode where everything is the same, and there is an extra entity here where we have the privilege of keeping a pressure support as well. So when the patient has a spontaneous breath, we just support that particular breath with an extra pressure, so that his breath is also taken up. In the sense, probably his breath would be only around 150 ml. Just to support his breath, we can give a pressure support and augment it to somewhere around 300 to 400. So these are the basic steps which when we have to connect a patient onto a ventilator. So if there are any doubts, we can go ahead.
Okay. Thank you, Vivek. If we could get that. Now, in case even this doesn't work, you want to say something?
Yeah.
Yes, Jacob?
I think, I know how many of you have got it, but simple thing, volume control is as good as a safe ventilation for you to begin with. Now, I would like to put certain things also, because sometimes, I know some of the centers where the patient is on obstetrics unit or obstetric ICU, where the patient is put on a ventilator, and the call will come mainly when you ask for it. Now, when to ask for it? Because one of the important thing in all ventilator patient is the alarms. Alarms keep running. So for you to know, a practical tip is that what you have to worry about is one important alarm called as a pressure alarm, which is something which you will come to know in a machine. The alarms will keep on beeping, whereas a high pressure will keep on coming. Now that is the only one thing which I would like you to remember for a beginner to do with, suppose you are handling a ventilator. Now in a high pressure alarm, there are two pressures which comes there. One is a peak pressure, one is a plateau pressure. Not confusing you, two terms, peak pressure and a plateau pressure. If the alarm coming is a high peak pressure, you have certain things, because the respiratory therapist will know that what are the mnemonics you remember for the, which is very simple technique we can make the patient better. High peak pressure alarm is definitely a problem. So what are the things you should look if the high peak pressure alarm is coming?
So if you're getting a high peak pressure alarm, first you need to start assessing from the patient. Make sure that the ET tube that is placed, the artificial airway that is placed, is not kinked or obstructed. And make sure that patient is not coughing or patient is not struggling with the ventilator. So after checking the patient, next we come to the connections. Even the HMV that is being connected for getting humidification can get blocked with the secretion. So make sure that the HMV is patent. And coming to the circuit, make sure that there is no water inside the circuit. And at the end, even ventilators can get failed. So in a simple term, there is a mnemonic called DOP, that is, first the peak pressure can happen when there is a displacement of ET tube, mainly to a right bronchus when they are giving the care, and the next one is obstruction. So obstruction, patient may be biting the tube, maybe the tube will be kinked, or it will be blocked with secretions. And the next one is P, it is for pneumothorax. A sudden pneumothorax, if the patient is having a sudden pneumothorax, the peak pressure alarm will be going up. And the last one is E, equipment failure.
So peak pressure alarm, first thing you look for is that is there any secretions. For a simple terms, do a suctioning and see the patient, the patient is not biting the tube, and a thorough suctioning will definitely help to reduce the alarm. Second one I mentioned about the plateau pressure, which is not a simple, it's a complicated term. However, the plateau pressure alarm is there, then the problem is not with the tube or the upper airway, it is there inside the lung, which could be a lung collapse or a consolidation or whatever major things. So peak pressure means secretions, tube bite, tube block, bronchospasm. A bronchospasm, a wheezing can also cause that. So these five things has to be addressed for a simple solution.
Okay. Now that if the invasive ventilation also fails, is there anything in our armamentarium beyond that?
Yeah, I think that is a question which, when do you say the invasive ventilation is failing? Of course, the most important thing is that you are not able to maintain the oxygenation. Now, for you to know that oxygenation, what target oxygenation you keep? You don't need a high oxygen. In a pregnant COVID, we have a target set is a bit different, 92 to 96%. However, if the oxygenation is not able to maintain and the lung is getting damaged by your ventilation, how do you know the lung is getting damaged? That is what the pressures come in picture. If you are not able to maintain the lung pressures under a certain point, that means that your invasive ventilation is harming the lungs. The third point is that pneumomediastinum, pneumothorax, the gas is leaking out with invasive ventilation. If you keep on ventilating with tidal volumes with your ventilator, that can cause further lung injury, which can further worsen the condition. That is the time when nothing is working out, still you need to continue your ventilation. You need to consider the next modality. What we all know is the extracorporeal support, which is called as the ECMO. Now, what about one more step is what about the prone ventilation? The prone ventilation definitely help to recruit the alveoli and improve oxygenation. However, in the pregnant COVID, especially in the third trimester, probably the prone ventilation may not be a successful thing to conduct. So we may not be, I don't think anybody, I have not done a prone ventilation in a third trimester pregnancy. So if the ventilation is not working, the next thing to go is that you consider what is called as an ECMO. What ECMO? Venous ECMO. So venous and arterial is there. Arterial used mainly when you need lung and cardiac support. Where here only lung is a problem, we use what is called as a venous ECMO. That is the next step which we can attempt if ventilation also is failing.
Do you have any picture?
Do
you have any picture of a treatment? Meanwhile, there is a question over here. Sitting.
Okay, I have one question here. This is an interesting question. How does one know which type of pneumonia is L or H type, and does it ventilator settings differ? Now, for the people who doesn't know about it, in the initial time of the pandemic, the autopsy studies or the CT studies have demonstrated two things about the lung, two pathology in the lungs. One is the lung which is low compliant, one is the lung which is high compliant. Now, is it really exist? I have my own doubts about it, because it is extremely difficult to differentiate between these two lungs. If you ask me what is the difference, my feeling is that in the early stage of the ARDS, the lungs are more compliant. So when intubating a patient in the early stage for whatever adequate reasons, the tidal volumes, the oxygenation, the pressures, everything remains stable, and we can see an improvement in the oxygenation quite rapidly. However, when ARDS progress to certain stage, the lung become less compliant, and your ventilator can cause definitely may not be able to achieve the target one. So difficult to diagnose. However, if you are intubating and if you are seeing a lung compliance, which you can see in the ventilator, or the lung parameters improving rapidly, probably there is a highly compliant lung, which is current H1, current COVID pandemic, current variant or whatever you call it as, the lungs are not at all improving. They are less compliant. Probably you are dealing with the less compliant lungs. And in the first compliant lungs, a volume control ventilation with an adequate control of the peak and plateau pressures will help to settle the lungs. And one more important thing is that what you have seen, one more thing in COVID pneumonia, COVID ARDS is that you give adequate time. The recovery of the lungs is always not very fast as other pneumonias. So most of our patients who are on ventilator, we have a pregnant patient who came on 28 weeks, we intubated, termination was not done, we continued the pregnancy, 10 days she was on a ventilator, we were able to extubate. So the time taken for the lung to recover is almost 10 to 12 days. And the current set of patients who is still on a ventilator, tracheostomy has been considered because the compliance have come down. So early phase of ARDS, probably compliant lung, a volume control will do. A later phase of ARDS, less compliant lungs, volume control or volume targeted ventilation may not help. You may have to convert into pressure control to achieve good gas exchange.
Okay. Thank you. And is that the picture of the ECMO? Just for curiosity of most of the people who may not have seen it, the ECMO.
This is a real patient who is on ECMO for almost 30 days right now. And what you are seeing is an ECMO machine. I'm not going to, because we will have two catheters placed, two venous catheters. Normally, one in the right femoral, where we take out the blood, and that's the machine you are seeing over there. You connect it to the ECMO machine, which has got an oxygenator. The blood gets oxygenated, and you instill into the right internal jugular, which is called as an inflow cannula. So drainage cannula is a femoral, inflow cannula is the right internal jugular. And ECMO will run, ECMO will have its own oxygen support. You will support the lung with minimal support. Basically what you are trying to do is that you are giving the lung rest. You are resting the lung, but don't keep it completely shut down. You keep a basic ventilator setting. Rate of around 10 to 14, PEEP of around 5, not more than that. air volume of around 250, FiO to 60, 60, whatever you want to keep. But ECMO will take care of the carbon dioxide removal, and the oxygenation is done by the ECMO machine. You give the lung rest, give time to recover, and then ECMO can be weaned off. However, what experience tells us is that even on ECMO also, patients are taking a lot of time to recover. We have currently 2 ECMOs running, and we are praying to God that these both will recover from the lung aspect. That is not working. The last stage is lung transplantation, which is quite difficult in our setting as of now.
Thank you, Jacob. Now that we have covered what we wanted to convey, one more thing I wanted to ask you. These days we get patients who have recovered and still needing some respiratory support. Is there any physiotherapy or anything that you would advise them when they go after having had an involved lung?
Yeah, that is another important aspect, because almost all the patients who is on a ventilator almost all the patients who is on a ventilator support it is important that they get an active physiotherapy, because the limb and the chest wall muscles needs to be prepared for the recovery. It starts with the patient when he's on a ventilator, and then you continue with that. Post extubation is again important that you continue with the physiotherapy, and we will have a demonstration of some devices which we normally use in our setting. Slideshow. Done. Okay, this is the one study I mentioned just before I forgot, because a surgical mask on top of HFNC can improve oxygenation in patients hypoxic respiratory. A small tip which can help you to optimize HIV. Now over to Della for lung rehabilitation.
Okay, moving on to pulmonary rehabilitation. What we commonly do in our ICU is chest physiotherapy and incentive spirometry. So chest physiotherapy, this is actually we keep our hand in a cuff shape and we'll give tap over the chest. So based on the bronchopulmonary segments, we have different positions. I'm not going deep into it. So you can give, if the apical segment is affected, you can ask the patient in a sitting position, you can give it. And if the anterior portion is affected, you can ask the patient to lie in a supine position and give. And if the lateral portion is affected, keep the patient in a lateral position and provide the chest physio. And for giving the chest physio on the posterior side, you need to ask the patient to lie on a prone position. So next, this is something that we commonly use. It's incentive spirometer. So this is used to improve the lung expansion. Even after post procedure, we ask the patient to do this. So the mechanism behind incentive spirometer is sustained maximal inspiration. So in simple terms, ask the patient to take 2 or 3 breaths normally, and then ask the patient to take a deep breath and hold the breath for 2 to 3 seconds and exhale it. So we have 3 balls. One is 600 ml, next is 900 cc, and the last one is 1200. So once a patient is able to when the patient starts to take the incentive, sometimes some patient will be just blowing the first ball. So after practice, the patient will be able to blow the 3 balls. So okay, my colleague Alan will demonstrate this one. So first, ask the patient to take normal breath, 2 to 3 normal breaths.
So yeah, incentive spirometry is the other one to make sure the lungs
This is
get
for lung
back.
expansion.
Okay, thank you very much. I think these are the few things which we thought we will convey to you, and we have requested to our colleagues for their comments, Ambujam as well as Shamshad. Venu, if you could allow Ambujam for a brief review. Anything else you want to convey?
Yeah, I've asked both of them to unmute. Ambuja madam, please unmute here. Ambuja madam, please.
All very practical and very useful information. We got a basic idea regarding how we should go about step by step in ventilating a patient to provide respiratory support. Very useful session. Thank you very much, Piley sir, Dr. Jacob, Dr. Sachin Varghese, and the whole team. One thing I would like to ask is, we now understand that once a patient needs invasive ventilation, we have to go for evacuation of the uterus. So can you just explain how it will change the ventilatory settings and how useful it will be? What will be the changes that you can observe once the uterus is evacuated, that is in a pregnant patient?
Definitely, with the respiratory mechanics changes, what is happening in a pregnancy, once the uterus is evacuated, definitely the respiratory compliance, the diaphragmatic excursions, everything will makes the parameters better. We can see a lung compliance which is improving, the first thing, and we can see the resistance, airway resistance which is coming down, and definitely we can see the ventilation much more easier. However, I would like to put one important question over here. The hypoxia in a pregnant COVID is predominantly due to a COVID pneumonia and a COVID ARDS. Unless that is corrected, evacuating a uterus will have some definite improvement. However, you may have to continue. I think let me put an example of the current patient that Dr. Piley sir and my team is having in the ICU right now. Delivered LSES, she came with a COVID pneumonia. Yes, definitely, if you ask me, delivered outside and then referred to us in view of respiratory failure. Definitely her oxygenation, her ventilation is better probably once after the delivery. However, she is still having a COVID ARDS, still her lung requires almost 70% oxygenation with a ventilator support, and she is taking her on time. So improvement with regards to compliance and persistence and all the lung parameters will be there. However, the COVID ARDS is still persisting. We may have to be careful. Don't expect a dramatic improvement if the ARDS is the primary cause.
Thank you, Jacob.
Thank you so much. And I think Dr. Shamshad will be having some expert comments. Over to you, Dr. Shamshad.
Okay, thank you, sir, Piley sir, and also the Rajgiri team. It was really, we heard a lot, I think so, because the classes have very cut short, and at the same time you have demonstrated as well as explained almost everything. But because most of the topic you have covered it just very nicely. And one thing that I want to ask to Dr. Jacob is, which is more, that is when we compare with all these NIV as well as intubation, which one is earlier? You said when we put the tube, when we intubate the patient, when the lung complaints is there, that is as far as early, because we all know that the lung changes are occurring every day, that is decreasing, so that the tidal volume is getting reduced. We prefer always low tidal volume to keep as well as ventilation. So you said, so when we have to intubate, is it early intubation or a late intubation? We will try all the methods, that is NIV, NRBM, like that. After all these, at the end of it, when we were not able to maintain the oxygenation, we will put the tube. So when we have to intubate, is it an early or a late one? That's the only question that I have to ask. And yes, okay.
You give the most controversial question to the last, madam. However, let me answer it in a holistic way. See, a couple of things. One, the observation what we are seeing over the COVID pandemic over the last 1 year is that the current variant maybe, or the current set of ARDS, the lung budging is not as good as previous one. Because my point is that when you classical indication for invasive ventilations, when you do it the last some time back, the lung compliance is very good. They used to recover reasonably well. We are not seeing nowadays. They are taking a lot of time. That makes we also think that is intubation, or can you avoid intubation to prevent lung injuries and prevent secondary infection, especially because one of the challenges of early intubation, which is maybe true in a patient, is that the chance of secondary infection in our country, our setup is very, very high, and that can definitely cause a lot of damage. Having said that, let us not look into the early or the late stage. Now, a patient comes with hypoxic respiratory failure. You initiate it on a modality. Suppose you initiate on a high flow nasal cannula. You watch the patient not over the next 2 to 3 days or whatever time you have set. Daily assessment will be there. If the patient is not improving, as per the current gynecology American Society guidelines, HFNC not failing, intubation is mentioned, NIV is not mentioned. However, I bet to differ a little bit in that because the resources, the ventilators, the challenges on a ventilator pregnant patient, everything is going to be a bit challenging. So I would like to put a middle path in this by saying that you try an NIV. You put a patient on NIV, make a sincere, cautious attempt optimizing all parameters what you know to make the NIV correct. Suppose if the NIV is not working. How do you know NIV is not working? 2, 3 things. One, oxygenation not improving. Number 2, patient getting tiring out. How do you know patient getting tiring out? One, you are seeing the respiratory excursions, you are seeing the accessory muscle being acted, and when an ABG is taken, you are seeing the carbon dioxide going up. So that is a time, despite you're trying on NIV, may be more harmful than for the patient, you consider invasive ventilation. So, non-invasive ventilators, sorry.
Yes, you can continue.
Non-invasive methods are always good. We have to optimize in our country because of the infection rates are very high with an invasive ventilator and pneumonias are secondary infections are very high. Non-invasive modalities needs to be optimized and give a try. But if it is failing, plan for an early invasive ventilation. And
Yes,
this
okay.
that the lung is going to take a lot of time. The current set of patients which has come with an ARDS for recovery, and we have now moved to a reasonably early tracheostomy because tracheostomy makes the airway clearance, makes the patient's tolerance a bit better than a tube in the mouth, and probably we can have better mouth cleaning, everything which can have some value on preventing infection. So tracheostomy is something which we are considering now to do it a bit more early than what we used to do it before.
So another question is there any role of giving surfactant to correct the ARDS? Just like we are doing it in neonatal severe acute respiratory distress syndrome, some of the journals that we have seen that the treatment with the surfactant is helpful. That is, 1 or 2 patients have recovered after giving this surfactant. So after the ECMO, that is, they says that they have kept even the patient in ECMO for about 6 to 8 days. And even then the PFR is started decreasing. That is up to after 150, 148, something like that. They tried the surfactant treatment, and then the patient is found to be improved much faster, and they have they could extubate the patient better. Is there any role like that, the surfactant that we can try or anything like that?
Sure, madam. I think, the pandemic has made people try a lot of things. We all know that.
Yes, okay.
The drugs, and when you are pushed to the wall, we will try anything. So, in the surfactant per se, apart from use in neonatal ARDS, where neonatal patients has been used, none of the adult ARDS, be it in H1N1 infection or any other ARDS, because even though we know that the pathophysiological mechanism is loss of surfactant, that is, we all know replacing a surfactant doesn't have much of a value because the lung is already been destroyed not only by surfactant loss but also by the complete loss of alveolar architecture. So surfactant replacement physiologically or theoretically may not have a value in a patients with an COVID ARDS which has multiple pathophysiology happening. And one of the important pathophysiological mechanism in COVID is thrombotic phenomenon or a thrombotic event. So that also holds good for this hypoxia. So having said that, surfactant value may be questionable, but let me put it across very clearly. Anecdotal case reports, 1 or 2 case reports definitely will be there, and that I consider that patients are really lucky because somebody has tried with a wide range of thinking and it has worked. So as far as I know, surfactant replacement may not have a value in a COVID ARDS as of now. However, tomorrow things may change if enough data is there. I have one report to tell that there is one more guy who was come with a COVID ARDS. ECMO machines was not available. He was hypoxic, and we tried nitric oxide, inhaled nitric oxide, which is something which is a pulmonary vasodilator which helps. And we were able to maintain oxygenation for some time, 2-3 days, and in the meantime we prone him on INO and his lung recovered, and we did not use an ECMO machine for him, and he survived and went back home. If you ask me, am I going to use INO for all the patients? No. However, it was a push to the wall, last ditch resort to save that particular person. It sustains his lung for some time. So these kind of things definitely will be there, and pandemic has definitely changed or practices has been put here and there, and reports definitely will be there with surfactant. Theoretically or any data-wise, I don't be able to support it right now, madam.
Every day the newer suggestions are coming. And what you have said, one thing point that I have to congratulate you, Rajagiri team, is that because of your infrastructure is so good, that is, you are depending on the chest X-ray, CT X-ray earlier than the chest X-ray, because even before we get the changes in the X-ray, we will get the changes in the CT. That is very good suggestion. And now we can't afford to it for all patients. And that's a good suggestion that because of your infrastructure facility, that was found to be able, that was a good suggestion. Because when we see the CT, we can see the more changes. And after only 1 or 2 days, then only we are getting the X-ray changes. That is good. Sir, it was a very nice talk. As far as anesthesiologists are concerned, we have got more of the interest, as well as at the same time, you made it into so concise. That's why I told that I heard a lot. Thank you very much, sir. Congratulate once again. Okay, thank you.
Thank you, Shamshad. And before I hand over to Venu for the vote of thanks, let me take this opportunity to thank Kfog for this opportunity, and also my colleagues here who have, please come over. And as you can imagine, it's after a full working day that they have stayed back and to help. And of course, some of them have to come early tomorrow morning because transplant and other work are waiting. So thank you, Vivek. Thank you, Alan. Thank you. Yeah, Bella. Please come over, the whole team. And two silent people who have been monitoring all your feedback, Raji and Saumya, please come over. And of course, Sajid also, please come. Yeah. So, and you heard all of them. Thank you very much for this opportunity, and I hope that it will be of some use to those who spared the time to watch it. Over to you, Venu.
Thank you very much, Paili sir and entire team. Like last time, Paili sir, one more request. I hope that before our next update, we will have a snippets which we can pass on. I shall pass on the questions in the chat box so that, I'm sure that we'll come out with snippets like we came out after the last session. I wish to thank, first of all, Paili sir and the entire team at Rajagiri Hospital, Dr. Raji, Dr. Saumya, Dr. Jacob Varghese, Dr. Sachin George, Dr. Julius, Dr. Vivek, and of course, Della, Alan, and Nitish. Take a bow. Wonderful demonstration. I think all those who attended today would have learned a lot from, and you people have taken so much trouble to put this session together. There were a few, I think it was technically a little bit challenging, but I think that it was worth the effort a lot. I wish to also thank Shamshad Begum Madam and Ambuja Madam for your very vital and crucial inputs. And of course, our President Ajit Sir, though silently, I think he's one of the motivations and always inspirational and in support of all these activities. Thank you very much. And Kaushik Sir, I think this time we are a little bit better off than last time. Thank you very much for, even though he's from UNICEF, he takes the trouble to sit throughout the session. And thank you very much, Kaushik Sir. Thank you to all. And till we come up, and to each one of you in the audience, thank you very much. Our thing was streamed live on YouTube and it will remain there. So even those of your colleagues who have missed it can click on the link and view it even subsequent to this. Thank you very much. Very good evening to all of you, and take care. Till we meet next time. Thank you all.
Thank you, sir.
Thank you, everyone. Take care.